recently sat PACES 23 and managed to pass on my first attempt with a score of 91%. In this video I'll be going over my experience of the PACES exam, the new exam format and what that is like, as well as all of the strategies that I use to pass PACES. I tried making this video a bit shorter, but actually I think it's more helpful as a longer form guide, so I've timestamped down below, and please feel free to jump to the bits that you need and skip the bits that you already know. I highly recommend tuning into my experience of my exam. I'll be going over exactly what came up, I'll be reviewing the mark scheme, and I'll be telling you my experience and how I was feeling in those moments, because before this exam I really didn't think I could pass PACES, and I managed to do it. If you need any help or any questions at all, put them in the comments. I do actually answer comments, and if you do find this guide useful, please share it in your PACES group. It's good PACES karma and it helps me out a load, and I really hope this guide is useful, and good luck with your exams. So if you're new here, I'm Dan. I'm a junior doctor currently living and working in London, and in my spare time I seem to make YouTube videos, and over the summer I decided to sit PACES. Bit of a background on me, I'm now like an F7, so my career has been very atypical post F2, and I've had multiple different avenues which I've tried to explore. The recent one, I quit my job and then I've come back. I did a bit of GP training over the summer that didn't quite work out, and I think realistically I've had a number of episodes of burnout, and that has really clouded my judgment that I've made with my career. Feeling a lot better after a bit of time off last summer, I came back and decided to sit PACES because I'd managed to get my part 1 and part 2 in 2020. So the first thing to talk about is deciding to sit the exam. I made the decision to sit the exam last summer, and I actually decided just before the window opened and ended up applying in July of 2023. So as I said, I think my knowledge had long left me. I sat MRCP part 1 and part 2 both in 2020, so I'd had 3 years gap, but I had gained a load of experience in those years, and actually I do think that was helpful. Over the last few years, I think I've made PACES this big thing in my head. It is a really tough exam and you can get mugged over, but actually for me, I had made it this big limiting belief, and at points in the last few years I just resigned to the fact that I was never going to finish MRCP, I was never going to sit the exam because I wasn't good enough. And actually, as much as this is a tough exam, it can mug you off, it can be really unfair, and it's no reflection of who you are as a doctor and how good a doctor you are. It is a passable exam, and I think sometimes that message is lost because there are some people that get really unlucky. You can pass this exam, and although I've spoke to people and they have failed, sometimes they get super unlucky. I'm not saying that people don't, but often people actually know exactly why they failed before they even get the result, and it turns out to be true. It is a passable exam. That's not to say it has any reflection of you as a doctor, so don't conflate the two. And also, it doesn't mean that people don't get super unlucky. There are people that are fantastic doctors that are really well prepared that fail this exam. So timing your PACES exam, would I have done it differently? I think a lot of people rightly say that you should do MRCP part 1 and part 2 and then do PACES, and obviously I had a big gap between the two, and I think a lot of people would dissuade against that. I think it is helpful to have that knowledge, but actually the knowledge in PACES is slightly different, and it's not about the content and it's nowhere near the volume of the written papers, but it's actually the way that you package that knowledge and how you look as an overall polished doctor. The fact that it's marked across 7 domains kind of gives you a clue that they're not looking for a specialist here, they're looking for a good, polished, finished package of a general doctor who is safe. So as much as it could be helpful to have razor sharp knowledge, I do think probably for me, I found that the knowledge was less than I had anticipated that I needed to know in PACES. I picked up some of that knowledge just through experience in the last sort of few years. And I also think the last few years of experience as an SHO probably helped my things like clinical judgment, my communication, as well as my examination practices. And that actually was very helpful. So if you have just done part 2, go for it. Absolutely, you've got the razor hot knowledge, do it. But equally, if you have had a bit of a hiatus or you've had a gap or you've been on maternity leave, it doesn't really make that much of a difference in my opinion. I have benefited from ongoing experience since that time, but actually I think it is really doable. Like I've said, PACES isn't about knowledge. It's about the way you package the knowledge and how you look as a full package, the way you examine the patient, the way you are with the patient, and the way you think about your patients. There are crucial bits of the knowledge that you do need to know, so do not get me wrong. There are bits that are so strange, these little snippets of knowledge that everyone in PACES knows, and you do need to know them. But overall, I think it's a far smaller volume of knowledge that you need to know compared to the written exams. Those written exams are huge, and this is nowhere near that. There is a lot of work that goes into PACES, but it's not just revision. And a point of that is PACES is a bit like maths, in algebra, where you could show your work, and actually if you had an error carry forward, you still get some marks. You can get the wrong answer in PACES, and you can still do, I don't think you can get full marks, but you can do very well and still pass, even though you didn't get the diagnosis in your neurology section, for example. So signing up and timeline. So when you sign up to MRCP, it'll be all through the MRCP website, just like part 1 and part 2. To be eligible to PACES, you have to have done part 1. Most people will do part 2 as well, and I think that's probably sensible. It's a lot more clinical knowledge in part 2, which may probably be more helpful for pacers than the part 1, but you can do it whenever. My window for context was July to August of 2023. I don't know the exact dates, but I signed up, I think, on the 25th of July. Once you've signed up, you will then be ranked, and they try and do this sort of with IMTs first, and then they go down the order. I was a locum non-training doctor, so I was quite nervous that I wouldn't get a place, but actually I was lucky and managed to get a place. Once I had applied, I got an email confirming that they had received my application and that they were going to rank me and see if I got a spot on the actual exam date. When you're signing up for the exam, they do have this thing called a special request form box, and I think apparently the colleges are very good at trying to accommodate, especially trainees, with their dates. So then I got an email on the 2nd of August, so just after the window had closed, and that was confirming that I had got a spot. And for me, it was a application outcome category 4 email. I think category 4 was my priority list, so I think I was right at the bottom. But the fact that I was a UK based doctor, I think pushed me up the list in category 4. There were some people that were waitlisted in category 4 this year, so I did actually get quite lucky. Importantly, this email did not give me my date, so I didn't know my date, and they said they were going to write again on the 25th of August, so that was then 1 month before the start of the exam window, and give me a date. So there was a potential that I had 1 month just of revision, and I did know that and recognise that at the time, and that's important to realise when you're going to get told your date for the exam in relation to the exam period. This will all be sent to you in an admission document, and they should both confirm the location and the date of the exam then. It's important to know that actually you cannot sit pacers where you've previously worked, and they will ask you a bunch of questions about where you've previously worked when you're signing up to the exam. If for whatever reason you get an exam place at some place that you've worked before, then you just need to let them know when you get the admission document that that's the case, and they should sort that out. Okay, so next is money and leave. Depressingly, I was entitled to none of this, and I feel like there are loads of questions about this, so I'm going to put it in there. So it's very expensive, actually. It's £657, I think, for the exam. This is tax deductible. I will try and find an article and link it in the comments that is useful for that. However, this exam fee is not covered by your study budget, which I think is mental. I am not a trainee, obviously, so I wasn't entitled to it, but it's a mandatory exam. Please, someone explain why this isn't covered by the study budget. I don't know. So I didn't get any study leave either, but I was speaking to the guy that ran our PACES teaching, and he gave me some information about what you can expect. This may not be completely up to date, but I hope it's just a bit of an idea. HE will pay for one PACES course for IMT trainees. Ask PACES in London is, I think, the most expensive that I know of, and that is £1,600. Exam fee is not covered, as I mentioned, but exam travel costs are covered. This includes hotels, trains, and petrol. Let your supervisors know very early so they can try and give you the leave so you can actually sit the exam. If the exam is far away from where you're based, you may need multiple days of leave, and I've heard of people getting up to 3 days of leave if they're in like rural Scotland or somewhere. And in general, most people stay the night before, and I think that is a really good thing to do. I did it. I was in Margate, which isn't that far away from London, but actually it was a train strike, and my exam was like at 10:30 in the morning. And 100% that was the right thing for me to do, so I stayed the night in Margate. As you probably all know, the exam has changed. It was the exam format that I sat, so I was the first diet to sit the exam and the only diet that has sat the exam as of recording, so I hope this is a helpful insight. So the exam format changed in 2023. Whether that's a good or bad thing, it doesn't really matter. I would focus on the new exam format and get familiar with it, because actually that is helpful for your exam. The new bits are Station 2 and Station 5. The exam is split into communication scenarios, 20-minute consultations, as well as clinical system exams. And it's the 20-minute consultations, of which there are 2, Station 2 and Station 5, that are new. So just reviewing the website and what they say about it, these 2 stations aim to assess the way in which the candidate approaches a clinical problem in an integrated manner using history taking, examination and communication with a patient or a surrogate. On some occasions, the history will be delivered by a surrogate on behalf of the patient. Alternatively, the patient may provide the history. One of these stations is likely to be a patient with an acute presentation, whilst the other is likely to be less acute. For each case, 20 minutes are given with the patient to take a detailed history, carry out relevant examinations, and respond to the patient's concerns. 15 minutes will be allowed for history-taking, examination and discussion with the patient, followed by a 5-minute question and answer with the lead examiner. So I think that's a fair synopsis of what these stations were like, and actually how I would describe it in real life. It was like a clerking, or maybe not even a clerking, because some of them were a bit more outpatient style, but like a medical outpatients consultation. In that, you have less structure. Obviously, as a clinician, you can fall into bad habits, so do practice the structure of a history taking. I think taking a very detailed, structured history is important and will likely be much more fruitful in getting your diagnosis than actually the examination. At the same time, the fact that it is a more integrated station, it means that you can be a bit more liberal with your structure. I would definitely start with a history and do that. But if you remember things, or actually if you're running out of time and you want to start the examination whilst you take the social history, for example, I think that's a good idea. And when it comes to examination, there should be a clear system that you want to focus on, but at the same time, you don't want to do your 6-minute, like, I'm going to take the respiratory rate kind of thing. You don't have to offer for things like blood pressure or things unless they're relevant. And then if there's anything else, then you want to go ahead and examine that as well. In my teaching with one of the professors at St George's, he was encouraging me to give the patient something to sort of talk about. So educate the patient on what you think is going on, and then vaguely say your management plan. Often I found that actually then I would just repeat my management plan to the examiners, but it made me look like a very confident doctor. And actually, I think you're going to say it anyway, so you might as well say it to the patient, especially if you're running out of things to do. So the issue with this new format is that there has only been one diet that has ever done it, so you'll hear about my exam later in the video. There are some examples on the website, and there are scenarios, I think, from other resources. I would say that these are generally more natural than the rest of the exam, and actually feel much more sort of second nature to us as doctors. It's a bit more like an on-call clerking shift, but you're just doing it under exam conditions. So the communication encounters, I think, are fairly straightforward, especially if you're a UK graduate or you've worked in the UK for a couple of years. I'll put the stuff on the screen as to what they say on the website, but it's a 10-minute consultation. It was in the old exam, so there should be loads of stuff, resources out there. To be honest, I didn't practice it that much, but I think if you're an international graduate or you haven't worked in the UK for that long, I think it would be something to focus on slightly more. Basically, you want to try and be the best doctor you can be, and be super empathetic, super kind, and as much as there are points where you're going to have a difficult scenario and you are going to have to stand your ground, the importance is that you stay calm and deliver the message in a very professional, kind, empathetic way. I think with this, being sort of overly nice can go a long way, and not just with the mark scheme, but actually you are interacting with another human, and if they kind of like you, it's kind of harder for them to be difficult, even if that's what they're meant to do. That would be my tip. If you aren't that familiar with the UK system, I think things like that, or sort of UK health law, things like capacity, looking up a basic structure of Breaking Bad News, those are sort of your low-hanging fruit that I think would be helpful. And then the last type of examination is the examining clinical systems, and these are old again. These are your respiratory, neuro, cardiovascular and abdominal stations, and these are 10-minute exams. You have 6 minutes to examine the patient, and then 4 minutes to give a detailed presentation, give your diagnosis, your differentials, and have a little sort of viva with the examiner. And this should be probably the majority of your revision should be focused on this. It's important to get your examination skills down to a T, have a really good, slick routine, and do it under time pressure. As you get better, you will pick up signs and you will learn to interpret them on the fly, and then you just have to practice your presentation as well. This is like the hard bit of PACES, and this is, I think, the majority of the examination revolves around this. If you nail this, you're probably going to do well in the consultations, I would say. Just practice a bit of history taking, but this is the thing that is hard about PACES. It's nerve-wracking, it's not enjoyable, but actually if you get into a good routine, you get better at it. I ended up finding this like fairly fun, weirdly. Maybe I'm weird. But yeah, this should be the majority of your revision. This is where PACES is passable, is that if you practice your examination so that your skills are great and that you know your routine, so you're not thinking about what you're going to do next, you need to practice the actual examination, and then you need to practice the presentation. And the middle bit, when you're interpreting the signs, that should hopefully come with practice, but that's the bit that everyone gets nervous about. That's the hard bit, and you want to maximize your time and focus that you can spend on that during your actual examination. I think that is literally how you pass PACES. So good advice I got for different clinical stations. As I mentioned, I got a load of help from St George's, and there was one doctor in particular who helped me a load. He is the lead examiner for St George's, so once I heard that, I sort of hung around him like a bad smell and asked him loads of questions. I would encourage you to do that with your mentors at your hospitals as well. These guys do know all the knowledge and they have loads of experience, so just tap into that. But these are the tips that I think are really helpful and I found to be really invaluable in my revision. So with the consultation stations, there should be one that's more acute, one that is more outpatient based or chronic based. It does say that on the website, but I do think that is meant to be true. So in general, when I was practicing with this doctor, he always asked me to give more. So he was at the start encouraging me, like, what do you think this is? And actually that's quite painful. And he said, you know, you have to think like the reg. You're being an SHO right now and you need to be a reg. You need to talk about an opinion. You have to give your impression. You have to reassure the patient if they need reassurance. You have to give an opinion and then we can talk about something. But at the start, especially, I was being very meek. I didn't want to make any mistakes. I didn't want to sound stupid. But he said, you know, you do know this stuff. And actually, I was doing it in my clinical practice. You know, I work fairly independently on a ward, and I have loads of conversations with loads of patients and give my opinion all the time. I reassure them when they need reassurance, and I answer questions. And in this exam, you are expected to be the reg, so just go in with it and give a bit more. And I think it helps the exam sort of run more smoothly. I think when people talk about getting grilled, the times that I was getting grilled in the examination was when I hadn't really been that forthcoming with information, and almost if you give a consultant a topic to talk about, then you just talk about the topic rather than it being sort of more painful. So that is a really good piece of advice. Try and be the reg, try and be the, you know, embodied reg that you are. So the other really good piece of advice that I've kind of touched on is examining clinical systems. And essentially your exams should be completely second nature. You don't want to be thinking about whether I've done inspection and tone. You don't want to think about, you know, what reflex do I need to check next. This should all be second nature to you, and then you can focus solely on interpreting actually what are you examining, what are you finding in your examination, because that is what takes the most time, that is the hard bit, and you want to prioritize that so that you can pick up the clinical signs and you can interpret that and give a sensible diagnosis. If you do find yourself hesitating, if you do find yourself not quite knowing, then you need to practice more. And I would say that actually practicing on a normal person is quite helpful for this, because you're just trying to get that muscle memory, that routine going, and doing that with patients, it comes with a myriad of sort of extra complications, especially if they're in an acute hospital. Practicing at the start with a partner or a friend who is healthy and fit and obey your commands, that is a really helpful thing, I think, just to get your routine down. That isn't to say that you can only do practice on your partner, because you do need that patient experience. I think right at the start it's helpful for your routine, but you need to be confident that your clinical signs that you're picking up are actually there. So good example of this would be not adding heart sounds when they're not there. You want to be able to hear if there is a murmur or if there's normal heart sounds, and you don't want to conflate the two. The next example would be hyporeflexia. You know, so the lack of findings of reflexes. Is that just because you can't find reflexes? Or is that because you know that you've examined thousands of patients and tapped the patellar reflex so many times that you should get the patellar reflex, and actually there is genuine hyporeflexia here? So you do need to have that confidence in your skills, and that comes from practice. Other tips were around sort of never events of paces, and the first one of those is causing the patient pain. You shouldn't be causing the patient pain. That is fairly straightforward, but in paces that can cost you the exam. I don't know if it can cost you the station. I don't know exactly how they work, but just don't do it. You want to ask about pain before you sort of do anything, and then you probably want to ask again before you actually lay hands on the patient. Other things that you should be doing are looking for sort of wincing when you're touching the abdomen. So you want to be pressing the abdomen but actually looking at the patient's face. And if the patient is sort of uncomfortable or anything, just stop. Literally just stop. Equally, if you're about to mobilize a patient but they've got like a huge walking frame or a wheelchair, you know, ask the patient, how do you mobilize, and is it safe to mobilize you? And don't mobilize a patient that is potentially not safe. Again, your examiners are meant to give you anything apparently, but if you look at them, they have a responsibility for the patient as well, just as much as you. So do look at your examiners as much as you're not meant to. Why not? The next one is never listen to the chest through the clothing. So apparently this is like sacrilege in the PACES examiner world, and actually having done PACES and listened to lots of chests with just the skin, I can kind of see why. It's one of those things where it's a PACES thing, but actually it's a PACES thing for a reason, because actually I now don't listen to the chest through the skin. Actually, it makes a big difference. So don't listen to it through the skin. Apparently that is like, you know, like swearing in your exam to the examiners. It's not a good thing to do, so just don't do it. The next thing to talk about is exposure. So it's really important to expose the patient whilst maintaining their dignity. And I think a lot of people get their knickers in the twist about this. It's really, pardon the pun, what you have to do is go in and say, I'm going to try and expose you so I can examine you properly. I'm going to try and maintain your dignity. And you will over time get a sort of sentence that is helpful, sort of that just comes naturally off the tongue. And then invite the patient to sort of undress themselves, and just, if you are going to expose them more, you just say, oh, I'm just going to lift this up, is that all right? You know, if the patient is wearing a bra, you do want to have a look under the bra straps, because there can be sort of thoracotomy or very subtle sort of VAT scars that you don't want to miss. Equally, if there is nothing to see and the patient is having their bra strap lifted up like 5 or 6 times in the morning, the examiner, when you go to do it, should probably hurry you along and say, there's nothing to see. This, again, is so weird. Like PACES has all these weird sort of things that you have to do to pass the exam, and then you start doing them and you're like, oh, it does actually work. Like, there have been a number of times where I haven't exposed the patient properly in practice and I've missed something. And, you know, that's why you expose the patient. It kind of demonstrates its worth. But yeah, don't overthink it. It's really very normal part of your practice that you do all the time, to be honest. Okay, so back to me. After signing up, which did actually take quite a lot of courage and sort of me putting myself out there, I then had to start revising, which again was a process that took quite a lot of courage. This part is grim, and you just have to get through the crap. It's a bit like med school. You start overthinking things, you think you're missing things, you don't want to make mistakes, and actually you're, to be honest, not very good at it, because the exam requires you to do things in a certain way, in a certain time, which is really quite unnatural compared to your normal clinical practice. Just try and get through it. It's not very fun. You are going to be crap at doing a cardiovascular exam in 6 minutes and picking up every single sign and then presenting it immaculately to your examiner straight away right at the start. That's a perfectly reasonable situation to find yourself in. It was the situation I found myself in, and that is expected. It is quite a grim learning curve, and you learn very quickly, but that is also quite satisfying, and you do see your progression. So just try and get through the crap, and try and be brave enough to put yourself out there and be like, I'm crap at this, but I'm going to go and examine the patient, and I'm going to take a friend, and we're going to try. And you have to remember that actually every time something does go wrong or you don't get a diagnosis, then you're learning. Like, I remember a lot more when I don't get the diagnosis, and I learned so much more from that than when I knew that it was aortic stenosis and I just went through the motions. That is good practice, it's good to do, and it's going to probably come up, but you want to find cases that you don't know, and then that's when you learn, that's when you sort of join the dots, that's when you get the most out of your revision. So remember that actually not getting the diagnosis and failing is when you remember it. I remember I had this revelation with sort of crackles bilaterally and it being bronchiectasis, and it all, I don't know how I didn't realise that it was bronchiectasis, but I didn't, and then I remembered that it was bronchiectasis the next time, and I can sort of still kind of remember what the patient looked like. So tips for starting your revision. So firstly, I would start at home. I use the past test videos, and to be honest, although it's another expense and it is expensive, I did find it really useful. And I think when you're first starting your PACES revision, it gives you something that you're actually aiming for. I felt like I didn't really understand what I was meant to do to practice for PACES, and I didn't really know what a good PACES candidate looked like. But actually, this gives you a very good, if not like way too good, sort of perfect example of what you should be aiming for. And as humans, I think we find it easier to aim for something or emulate something if we've actually seen it. So the second thing is to start at home again. And I've kind of mentioned it before, but as much as I've said, it's when you do your most learning, when you don't get the diagnosis, and how much learning you can gain from that. And there's no sort of substitute for examining real patients and picking up signs. When you first start, you're not going to be able to do a lower limb or cranial nerve examination in 6 minutes really slickly, and that takes a lot of practice, and that's a reasonable position to find yourself in. Again, I was very slow. Do it on your partner. Every single night you want to do a few examinations. It takes half an hour, and you just want to get your routines done. I would probably spend the first week doing that, where you're just practicing on your partner at home, so you are going and getting that muscle memory and practicing. I would practice on a healthy individual who can obey all commands and try and get that down in 6 minutes, nice and slick, before you start doing it on the wards. Okay, and the next tip is so important, and I think this is where people go wrong. Every time you go to practice on a patient, do it properly. Set a timer for 6 minutes, and then following that, set a timer for 4 minutes. Do the examination properly. Do not say, I would do this in the real exam. No, do it properly. Expose them properly every single time. Make sure you're asking about pain. Make sure you're examining them from the end of the bed and looking around. Make sure you're looking properly as you're going to do it in the exam, so that it becomes second nature to you. This, I think, is a really helpful tip. And once you've done the exam, then you need to go and find someone to present to. If you're not with someone, just go, and even if you can't find anyone, which is not, that's not going to be the case, you just need to go and talk to someone and just present what you've just found. It's just that practice. They don't have to ask questions. They don't have to be able to understand what you're talking about. But obviously it's a bonus if they do. But just go and practice your presentation and get into the habit of talking about the patient that you've just seen. We don't do it. So why would you be good at it unless you practice it? You have to do it properly. Okay, so the next revision tip I would say is to tell people that you are doing it. This is uncomfortable. This is not fun. You don't want to say I'm doing PACES, because then everyone knows and you could fail. It's a really realistic outcome that you may fail this exam, and it may take you a couple of times to try and pass it. So you have to sort of be brave, be vulnerable, because actually telling people that you're going to do it is really helpful. People really help you pass this exam. There's loads of group work. You always need a partner. It's so much better going to the ward with a partner. They keep you there. They're able to sort of ask you questions. they're able to pick up on things that you missed, and it makes it more fun. You can then do 6 patients, 3 each, and then you go for a coffee, talk about what's going on in your life other than paces, because there's loads going on in life other than paces. So you have to make this as fun as possible, and finding a bit of a community is really helpful to do that. Like I said, in my experience, I found the lead examiner at St George's. I went straight to the top and I said, I'm doing paces right at the start. And he was really kind and he was really pleased. He said, okay, yeah, good luck. It's he said it's a passable exam. And he saw my face, he put a name to a face, and then I just turned up. I was a locum, so I could book days off. And when he was on call, I would just show up at the AMU. I was working in a completely different hospital. It's the same trust, but different hospital at the time. And I would book a day off when he was on call, and I would just show up on sort of the on-call day at like 12 when he'd seen all the patients that he needed to see. And I'd just float around and I'd ask if he was around. And if he was, then I'd just go and speak to him and say, are there any patients that you've seen on the tape this morning that are any good? And he'd go, oh yeah, I've just seen this one. That's a really good consultation case. And sometimes he'd come with me. Often he wouldn't. He'd just send me off. And then I'd go and examine the patients and come back to him. And he'd say, okay, so present your findings. And we'd go through it. And then he'd send me off on another one. And that is because I told him. And he was never going to come and find me. I had to go and find him. And that took a lot of, balls. I don't often go and introduce myself to people in that way when I'm after something, but he was so kind, and he is the teaching fellow. That's what he wants to do. He wants to pass people in paces. He wants to help people, and there are loads of us out here. I'm making this video, I hope it's helpful, but people, they have to know that you're actually doing it to be able to help you. So the next tip I would say is to have an accountability group, and I have benefited massively from having an accountability group myself over the last 8 months, and during that time I managed to pass paces. Not only that, I managed to stay fit, I ran a few marathons, I did some content creation, I worked on my camper van, and I was doing this YouTube stuff. I also figured out what the hell I was doing with my career, I revalidated, I did loads. And I put a lot of that down to the fact that I had a really clear structure and was reevaluating my life and where I wanted to go and be in my life, and then setting my goals every single week in account to those. I found this group so helpful, and at one point in sort of September, all I talked about was paces and what I was going to do with my paces revision, and I think it's a really helpful tool that I would highly recommend everyone implement. There's a video here about my whole experience and why I think it's a great tool that does actually work, and I was in a group with entrepreneurs who were not setting paces and didn't know anything about paces. So you don't have to be in a paces specific group, but I think it's a really helpful tool to keep you on track and to look at your life overall and think about where I'm going and what I'm going to do next week. If that is of interest to you, I'm setting up my own free accountability group every single Sunday called Self-Improvement Sundays. It's free to everyone, so it's not going to be a paces specific group, but I do think it's a really helpful tool in paces to have an accountability group. So if that's interest to you, check in the description down below, and I look forward to seeing you there. Okay, so now let's talk about the overall structure of our revision. So going back to my story again, I had booked in July, I then got a confirmed spot on the 2nd of August. I was then told that on the 25th of August I would get my date, and then the time came, I got my admission documents, I was told I was in Margate, and I was going to be examined on the 30th of September. So that left me with like 4 weeks at the time of getting my admission documents. So I wasn't that pleased with that. I was a bit stressed out about it, but I do think that having a shorter amount of time did focus me more. And it just goes to show that this is a passable exam. I'm not sat here telling you that it's a passable exam and that I had this super easy ride and had the perfect sort of exam date. That was a big shock to me, and I hadn't prepared for that to be my exam date, and I still passed. So do listen to what I'm saying. I hope it is of value. I do think it is of value. If you are finding it useful, then hit the like and share this with your paces group. I hope that if you found something helpful in here, then they may too, and it's really good paces karma as well. So like I said, I had very little time to get the result, and as a result I think the fact that I was structuring my revision very well, I was doing my weekly accountability group, I think that was all really helpful and kept me very focused on the goal, which was to pass paces. So this is what my revision overall looked like, and we can talk a bit about it, and any questions about any of this, just in the comments please. So week 1 and 2, this was when I just just signed up. It was in July. To be honest, when I say chill revision, I did very little. I started watching past test videos right at the end of these couple of weeks. I had watched a few YouTube videos, and mainly I was watching YouTube videos like this, like how to pass paces, but realistically I hadn't really started my revision. Mid-August, I then attended the induction to paces, which was held by the Paces Teaching Fellows at St George's, and that essentially was the start of my revision. We kind of went through a lot of what we've covered in the first half of this video, so like the exam fees and how to sign up and things like that, but that was when I realised, okay, I do need to start revising. Following that, week 3 and week 4, I actually started practicing. I signed up to teaching sessions, and the first teaching session that I can see that I went to in my diary was the 24th of August, and that was my first bedside teaching. Here, I met other people that were doing it, and I actually partnered up with a guy called James. He is a bit older than me, he's an IMT, and we worked together loads. I benefited so much from having someone that was dependable, that would show up when I said I was a free, and he was just like really keen to work. And I think in this period, you just have to like take what you can get, and we both passed, and I think that is because we practiced regularly. I found out my date the following day, and then accordingly, I've ramped up my practice because I had like 4 weeks left to figure out how I was going to pass paces. I had a good structure, so I then decided that I was going to wake up early every single morning before work and do 2 to 4 sort of past test videos and revise them and listen properly and try and take in what they were talking about. And that was what I was going to do before work. On my commute to work, I listened to the Past Paces podcast. I'll leave a link description. Some of it I don't think is all that relevant, but it's just a good way of sort of infusing your brain with stuff that realistically may come up that you don't see in clinical practice. So I found it helpful for things like thyroid disease. I found it helpful for things like Parkinsonism. And it's just a good way of exposing yourself to information that is relevant to this exam, because the information that is relevant to this exam is very specific and random. And then once I got to work, I would practice at work. So if I was on call, I would then go and see a patient, and rather than just, you know, go through the motions and do my clerking, I would, for one patient, I would do a cardiovascular exam, and I'd do it properly in 6 minutes. And that isn't not working, that is me doing my work, but I'm just practicing as well. I'd then practice at lunch if that was going on. There were some Paces sign-up groups, but they were quite oversubscribed, so I often didn't manage to get a spot on those. And then after work, I would practice again. And I did go in on days off, I did go in on weekends, and realistically, in this time, I worked fairly intensely for 2 to 3 weeks, and that was because I needed to. So in week 6, on the Saturday, so at the end of week 6, I then sat a course. It was Bite Paces. Again, none of this is sponsored. And that was a 1-day course. I wanted in my head to sort of be really prepared so I could treat this as a mock, because I, until that point, hadn't examined like 6 patients in a row. And this was going to be an opportunity to see what I was like under pressure over a period of time, and trying to avoid, you know, losing focus or fatigability, or, you know, losing my cool, or, you know, my bottle. And I found it a really helpful thing to have just a couple of weeks before my actual exam date to put in a mock. There are loads of courses out there. I will do a video on my review of Bite Paces and other resources that I've used, but it's going to be too much to put in this video, so stay tuned for that. Okay, so week 7 and then week 8, I took the feedback from the mock, I highlighted what I needed to do and where my weaknesses were. There's a really helpful website called Clinical Skills Pro, and they have an article where they highlight what comes up in Paces. And I then had a look at that, and I thought about what I was really, you know, quite bad at, and then looked at the most common things that were going to come up. So say if I was struggling with examination of the lower limb neurology, I then looked up neurology and highlighted which were the lower limb ones that came up frequently. And I did a bit of focus revision around that and just tried to sort of maximize where I could potentially pick up points or stop dropping points in the exam. I was basically just honing in all the skills to be more polished, because actually the sort of 2 to 4 weeks before I had really nailed down all of the sort of clinical practice stuff of Paces. And then it was my exam day, and so like I said, I drove to Margate, I booked a hotel the night before, and then I sat the exam at 10:30 in Margate. Okay, so I think that covers most of my revision, and now let's go into my exam. So again, if you have any questions in the comments below, I do reply to comments. So I will try and recall exactly what happened, and we will go through exactly what I think came up in my exam, and we're going to have a look at my mark sheet as well. If you are finding this content helpful, I'd be really grateful if you could subscribe to the channel and also just share this in your Paces group. It may be invaluable to some of your other colleagues, and it's good Paces karma, as I keep saying. So I got to Margate, and I stayed the night, as I said, and I was actually the very first day of this exam ever. So Paces 23 started on the 30th of September, and that's when I sat my exam. Just a note on Margate is that there is parking at the hospital, and the people who ran the exam, I think, were very good, very efficient. Everyone was very kind. Once we got into the exam, they sort of sat you in a group. There was a morning session that was going on, and then we were put into a room. At that point, you have to sort of mark your own Royal College number on a load of mark sheets, which was kind of nerve-wracking, and you're kind of stressed. So just prepare yourself mentally for that. Yeah, I think that could probably be improved by the whole exam. The Margate guys didn't tell us that they were running sort of 20 minutes late, so that also added quite a lot of anxiety. But that was my only complaint, really. They ran it perfectly. Other than that, everyone was super kind, super friendly, and 10 out of 10 to the Margate guys. So thank you very much. So you will probably be familiar with the carousel. We've gone through the examinations sort of separately, but the carousel is the sort of order in which you will be examined. I fortuitously was starting in station 1, so I knew that I was going to have my communication, then respiratory, and then I'd go to station 2, station 3, and that was actually quite helpful for me to know what was coming next and what to expect. The way the exam was set up, we were all taken to a corridor, and there was a table outside the door of each room. There were, I assume, 5 rooms, and each station was done in each room. So station 1 was at the end of the corridor, and station 5 was at the other end of the corridor, and then in between each examination, in the interval, when you had to read your sort of script and take any notes that you wanted to, which you are allowed to take into the exam room, you had 5 minutes to sit at the chair and table outside the exam room before you go into the next room. So I'm now going to go through all of the examinations that I think came up for me. So station 1 was communication followed by respiratory examination. In my communication scenario, I was given a scenario of a patient who had been admitted 8 weeks before with a history of being generally unwell as well as severe back pain. They'd had an MRI, and that had shown initially that it was probably discitis, but the radiologist and the treating team had recommended that the patient needed a CT and a biopsy in order to confirm the diagnosis. The patient, however, declined further investigation and was discharged on OPAT and had 6 weeks of IV antibiotics for the treatment of the discitis. However, during the 6 weeks, the patient continued to decline, and they were readmitted with fevers, back pain, and being generally unwell. A repeat MRI on the repeat admission demonstrated likely malignant pathology and extension of the lesions throughout the spine, which were likely bony mets. The MDT had reviewed the images and had agreed of the likely diagnosis, which was awaiting biopsy confirmation. And you were asked to meet with the daughter and explain what has gone on, and she is concerned that may have been something missed. So before I went into this scenario, I knew that it was really important to be very clear with my timeline, and so I wrote this down as I was sort of preparing for the exam. So I basically wrote this down, and then I knew that I could familiarise myself if I got lost at all when I was explaining it to the daughter, because I knew that actually if I got the dates wrong or, got the timeline wrong, then this would all just fall apart. I wasn't entirely sure if the scenario wanted me to explain to the daughter just the scenario, or if she actually needed to be broken the bad news. So I went in kind of expecting to need to break the bad news, but what I thought the scenario was asking was me to explain the timeline, and then when the daughter said, has something been missed, me to explain that actually nothing had been missed. We had respected her dad's autonomy at the time, and although it was horrible and unfortunate, likely the lesion that was seen initially was actually metastasis, which we would have picked up had we, done a biopsy, but we didn't. That was because we respected his autonomy at the time, and that is completely right thing to do. And it was very unfortunate that it was actually cancer, and likely this patient is going to, need treatment in accordance to the probable very bad prognosis. So like I said, I went in, I introduced myself. Very quickly, the daughter did make me aware that she was aware that the patient had likely got cancer, and so I could just focus on explaining the timeline and then answering her concerns. Well, as we were going through the timeline, I sort of asked, if she remembered that and recalled that, and especially around the fact that her dad had declined the biopsy and the further investigations at the time of the initial admission. She was actually a really helpful and kind actress and sort of gave me loads and said, no, I recall that he didn't want to do those, further tests. He just wanted to get home. And after that, I sort of just went through the timeline, and then we came to the daughter's concerns. I think it's always really important throughout this PACES exam to ask about ideas, concerns and expectations, or your ICE, and that's what I was taught at uni, and that's what I still use. And I addressed her concerns, and she said, I'm just worried that something has been missed. The whole time I was making sure that I was very empathetic. It's a pretty grim, scenario, to be honest. And, I think naturally you will be empathetic in your communication with your patients. But I had to, at this point, say, nothing had been missed, because we respected the autonomy of the patient. That was the right thing to do and is important to do. And if a patient has capacity, then they can make whatever decision they want. But it's really grim and a horrible situation that we find ourselves in. And I think she probably did ask, actually, if the discitis was discitis or if that was the original malignancy. And I had to explain that it was likely that, that was an original malignant process that we hadn't picked up because we hadn't done the biopsy, and it had developed into, a more significant malignancy throughout the spine. To answer your concern about whether anything had been missed, I don't think that anything's been missed. And, a number of teams have looked at this. He's been through the MDT, and I'm reassured that we don't need to look into anything as sort of like being missed. I guess the whole time you just have to be super nice. It's not a nice scenario and it's going to be uncomfortable, but actually it was really fair and she was very helpful. So yeah, and as you can see in my mark scheme, I did well. I think this scenario probably just required a very good understanding of the timeline and then a clear explanation of that timeline to the patient's daughter, and then just basically explaining that although we are trying to find the diagnosis, sometimes we have to do multiple tests, and often then we still don't know. But even with that in mind, I don't think anything was missed, and reassuring the daughter that her dad got the right care and we respected his autonomy at the time. And yes, we're in this unfortunate situation, but nothing was wrong about the case. So the next station was respiratory, and I went straight in from the communication to respiratory. It was a lady in her 60s or 70s who was complaining of breathlessness, and I had to perform a respiratory examination on her. And this was a nice scenario. So she was well from the end of the bed, she was smiley, she had her gown very loosely placed, and so when I asked her to expose herself, she had a sports bra on, and that whole thing was very seamless and not a problem at all. I examined her chest from the end of the bed, and she was well. And then I came to examine her hands, and she had sclerosactally calcinosis, and then on her arms, and also looking at her face, I could see that she had a number of telangiectasia. And at this point, I was like, okay, this was the point in the exam where I was like, okay, I know what I'm doing. I know what the diagnosis is here. I know what I'm hopefully going to hear on the chest. And I was like, okay, I can pass this exam. And that's because all my practice had come. This lady had CREST syndrome. I was anticipating that when I got to her chest, I would find bilateral, fine, end-inspiratory crackles. And that is exactly what I found. She had interstitial lung disease secondary to a connective tissue disorder, which I would speculate would be CREST syndrome, and I would confirm on antibodies. That was a nice feeling. And hopefully you get a nice, easy one at the start of your exam, and you can just sort of be a bit more relaxed and confident going in. So the next station was station 2, and that was the first long form consultation. The scenario that I was given, I was asked to examine a lady who had unilateral facial pain. She was a lady in her 30s and didn't have any other significant past medical history. She took the oral contraceptive pill, but otherwise was completely well, didn't have any allergies or any drug history. She didn't have kids, and I was seeing her in an outpatient clinic. When I read this scenario, I felt it was quite an odd scenario, and the first thing that came to my mind was trigeminal neuralgia. But obviously, I think the point of this scenario was to try and assess what your differential diagnosis is like, what you consider, and this is, a lady of childbearing age. I think that was another thing that you had to acknowledge, that you recognised and thought about. I was a bit freaked out and a bit unnerved, but I was like, okay, I'm just going to cover my bases because that is what I should be doing as a safe doctor. So the sort of differentials that I had thought about from memory and written down on my paper were, I guess, talking about vision and loss of vision or visual acuity, also loss of colour vision, and thinking about this is a woman of, sort of middle-aged woman. Does she have MS? Although this is like a very atypical presentation, just sort of demonstrating that I am thinking about these things. GCA, although like extremely unlikely in this kind of age group, another thing that you can't miss and to think about. Other causes of headache. So is it actually facial pain or is it a headache? Is that what they're trying to test, how good your history taking is? So subarachnoid, migraine, cluster headaches. Bell's palsy, is it actual facial weakness rather than anything? Ramsay-Hunt syndrome, so looking for any rash on the nose or in the ear. Venous sinus thrombosis, just the fact that she is a young woman on the oral contraceptive pill. As I mentioned, I thought about pregnancy, brief gynae history, and that kind of thing. I then also thought about parotid pathology, like from somewhere in the back of my mind. I think the facial nerve runs through that, or the trigeminal nerve, or some kind of nerve runs through the parotid. So I felt the parotids and things like that. And then generally just screening for B symptoms and looking for other signs of focal neurology. Is this actually a TIA? Is this a stroke? Although extremely unlikely. So in reality, I went into the scenario and as I've said, I was quite unnerved at the start. I was like, why have they given me trigeminal neuralgia in my PACES exam? That's so random. But then she gave this beautiful history of trigeminal neuralgia. So I could stop second guessing myself, and I was like, this is trigeminal neuralgia. And then I could relax and sort of go into the fact that although clinically this was trigeminal neuralgia, this was a young patient who had a presentation that, could be multiple things, and I had to demonstrate that I was thinking about other things and then make a sensible management plan with some kind of follow-up to, at some point question the diagnosis if her treatment hadn't improved her symptoms. I asked her like one open question and she gave me like the whole history of trigeminal neuralgia, which was great. I went through all those important negatives at the top, and obviously it was all negative, and she had no B symptoms. And when I examined her, did mainly a focused neurology exam, like cranial nerves and then upper and lower limbs. I had a feel of her head and neck, and just in general around the area. I had a look in her ears, went to like looking at eyes as well, and they were like, no, it's normal. So like at that point I was like, okay, this is a normal exam. And I guess that is something they were testing, like, can you not, sort of convince yourself that you're finding stuff when there's nothing there. And at that point I did a systems review, and then I actually finished with like quite a lot of time. So I went into quite a lot of detail with what I thought was going on with the patient, and ended up just repeating quite a lot of that when it came to talking with the examiners, just because I'd finished quite early. And I said, like, I think this is probably trigeminal neuralgia, a nerve in your face which can be quite painful. We can trial you on some treatment, and some of those treatments are sort of atypical painkillers like antiepileptics or old antidepressants, but they're very good at helping with nerve pain. I knew it was carbamazepine, but I didn't really know about pregnancy and carbamazepine. And so I said, if you are thinking about starting a family, then I'd like you to mention it to your GP and we can review your medication at that time. But I'd also like to see you in clinic again. If you haven't had any improvement in these symptoms, then we can sort of think about other things. But I'm happy that at the moment this is trigeminal neuralgia, and we're going to try and treat that. Do you have any questions? And she didn't have any questions, and that was that. It then came to talking to the examiners, and really we just talked about the same stuff. And I guess what they wanted to ask was, what happens if she comes back and she hasn't had any improvement? And at that point I said, you need to think about all the other differentials that I was thinking about. I said that you'd probably end up scanning her head, and if all those investigations had come back normal and this actually was, complex headache or complex trigeminal neuralgia pain, then a referral to a neurologist would be absolutely warranted as well, and ongoing care with them. And they seemed to like that, and yeah, that was the whole scenario. And then I had like 2 or 3 minutes just waiting. So as you can see, thankfully I was correct in thinking this was trigeminal neuralgia. Pretty random, but I guess they just want to see, do you have the confidence in your own ability and your own knowledge to back yourself? And it wasn't anything else, so it had to be that. But even saying it was like, it was random, but yeah. Okay, so the next station was station 3, and that was a cardiovascular followed by the neurology exam. So the cardiovascular exam I went into, I think I had a very brief scenario which was like non-specific. The patient was already topless and had his calves exposed, and I started from the end of the bed. I could hear a metallic click as I walked in, and I noted that he had a midline sternotomy scar, and notably no Harvest scars on either of his exposed calves. So again, actually they were really helpful in exposing the patient already for me. He was in sinus, he had some bruising up his arms, but other than that his peripheral exam was normal. But I got to the chest and I basically, I still don't know, he had a very metallic sounding heart basically, and he definitely had an aortic valve replacement, but I wasn't sure whether he had a mitral one as well. It was probably just aortic, just because that's more common, but I wasn't willing to just put all my bets on that. So I had to be a bit more strategic with how I was going to present this patient. So when I came to presenting my findings, I then wanted to sort of start with, I've examined this gentleman, and on peripheral examination he has bruising, he's in sinus, he looks generally well, and then on examination of his heart, that's how I wanted to set the presentation. So I started off going like that, and then the examiner interrupted and said, what's the diagnosis? I had been told that does happen, and the examiner was really nice, but that's how he was going to do it. And so I said, oh, well, I believe this gentleman has had a metallic valve replacement and is likely on anticoagulation. I found it difficult to ascertain whether it was a solely aortic or an aortic and mitral valve replacement, because his heart did sound metallic, but this gentleman has an aortic valve replacement and may have a mitral valve. replacement, both metallic and likely on anticoagulation. I don't know the cause of that, and I wasn't able to pick up any signs on peripheral exam of the cause. And to complete my exam, I would like to do a chest x-ray to ascertain which heart valve has been replaced. Yeah, I was able to say some sensible things like he wasn't in AF, he was euvolemic, that kind of thing. But I obviously dropped marks, and I don't think I would do it another way because actually I wasn't sure, and I still am not sure. And so I don't regret it, and I still passed the exam, but I did drop some marks, and I think I probably dropped it on like maybe the differential slightly, but it was probably the identifying physical signs. And then station 3 was neurology, and like I said, once you are in the room, then you move from one station to the next without a 5-minute break. So each station just runs all the way through and is 20 minutes in total. So I immediately moved on to the neurology station, and I did try and put like the cardiology thing back to the back of my mind. I don't think I quite fully did it because I wasn't quite on the ball with my neurology one, but I tried. I was asked to examine a lady who had presented with increased unsteadiness, and I was asked to do a upper limb examination. So I found that she had a rivaroxaban band on her wrist. I didn't quite put all of that together at the time, but going on to examine her, she had a right-sided weak arm, and she had hypertonia, hyperreflexia, and then examining her coordination, she was like wildly ataxic. And so I thought this lady had likely had some kind of lesion in her right cerebellum. I knew that that was probably most likely a stroke, but I went through my whole like lesion of the brain, or upper motor neuron lesion differential. So it could be space occupying lesion, you know, tumor, or it could be acute, and then it could be a thrombus or a bleed. And then the examiner sort of like prompted me, and I kind of remembered that she had a rivaroxaban band on, and then all the sort of like dots connected, and I was like, oh, okay, so this lady is probably in AF. I haven't examined her pulse, but to complete my exam, I would do that. She's probably on rivaroxaban for her AF and has previously had a stroke, because AF is a big risk factor for stroke, and that is likely a stroke of her right cerebellum, which is leading to her presenting like this. And although I didn't quite have that all together by the time I started my presentation, I managed to sort of like talk my way into it sounding very succinct, and having actually just, he was a nice guy, and we just had a conversation between doctors, and I was able to demonstrate that I had picked up the signs that she was, you know, rivaroxaban. I hadn't picked up that she was in AF, because that's not typical of an upper limb exam, but you could do that. And although I hadn't done that, I said I would do that, do an ECG, and then we went into all of that, and I kind of managed to sort of demonstrate my knowledge. And I obviously examined her well and picked up the signs that she was likely had a right cerebellar lesion, and then I was able to sort of deduce the etiology of that. He actually marked me full marks, which I don't think is unfair, but I think it just goes to show that like it doesn't have to be beautiful. It doesn't have to be like they do on past test. I don't know what I would have got if I hadn't said all that stuff about AF, and I probably would have done okay, but I would have dropped marks. And actually, although I didn't do it and know it right at the start, I was able to demonstrate that I had got it and talk about it very sensibly, and actually he was able to mark me. So people talk about like not leaving stuff unsaid in your PACES exam, and I think that's a really good tip. You know, they want to mark you, and they can't mark you on stuff you don't say, so just say it. So the next station was communication, and this was communication station 4, so it was communication and then abdominal exam, and this was a much more barn door breaking bad news. So I'll read the scenario that I sort of jotted down on my phone after. So a man in the 50s had presented to ED with a STEMI overnight. He had been reviewed in ED and taken to the cath lab, where he had an attempted PCI. Unfortunately, during the attempted PCI, he had arrested, and despite efforts of working on him for over 40 minutes, the team were unable to achieve ROSC. The wife has been called in, and she is unaware of the situation. You are the night reg, and you have been asked to break the bad news to her. So compared to the other one, I felt this was much more straightforward. I knew what I was going to have to do. So again, I introduced myself. I asked the wife to explain what she thought had happened and check her understanding. I tried to figure out what was the last thing that she'd been told, and what her sort of latest update was. And I also then asked sort of like, how did you get to hospital, and were you with anyone? Which was kind of like a polite sort of pre-warning shot. And I can't exactly remember how I did it. There are lots of structures to breaking bad news, and I was taught one at uni, which I sort of use still, and it is relevant for PACES, so we'll just talk through that. But I essentially gave her a warning shot, and then delivered her news, you know, that her husband had died fairly early on in the consultation. I must have said something like, "You are correct, your husband was very sick when we met in the ED last night, and unfortunately I have some really bad news." I then went on to say that, you know, despite our best efforts as a team to unblock the vessel in his heart that you mentioned was blocked, He went into cardiac arrest, which is where his heart stopped beating, and unfortunately were unable to get him back after working on him for 40 minutes. And sadly, despite our best efforts, your husband has died. I sat there waiting for her to respond, and then when she did, say the first thing, I then said how sorry I was and reiterated that he had died when she asked me again. And then the rest of the consultation was mainly just around reassurance and talking about the next steps and explaining that we will help her along the way. Bereavement will be in touch. Is there anyone she needs to call? Is there anyone that she wants me to break the bad news to again? And how is she getting home? So like I said, I think this was much more straightforward and barn door sort of breaking bad news. There is loads of teaching around this, so if you are unsure, go and have a Google of how to break bad news, and I would essentially follow that structure. Always check their understanding before. The next thing to do is to fire a warning shot, and I did this after I checked the understanding. I said, yes, you are correct. He was very unwell. We took him to the cath lab to try and unblock that vessel, and unfortunately I have some very bad news. And then the next message that you want to get across very clearly and fairly quickly, you don't want to dawdle in breaking bad news. I think it's not very nice and a bit cruel. So you want to have said the bad news within the first 1 to 2 minutes, I think, of the consultation, because what else is there to say? There's this thing that the elephant in the room is the bad news. So you then want to say without ambiguity that the patient has died, and you want to use those words, died or dead. You don't want to say passed, anything else. It's important to not leave any ambiguity, because then you just get yourself in an absolute mess. And then the next step, once you've delivered that, you then want to just be completely silent, and you don't want to say anything, because if you talk then, you're going to just get yourself into a knot, and the whole, you'll end up talking too much. That's when your scenario breaks down. You want to wait for them to then say something. If they take a bit of time, just nod your head, be reassuring, maybe put a hand on their knee, or hold their hand, or offer them a tissue. Let them speak first. And then after that, you answer any questions, but realistically, the consultation is over at that point. They're not taking anything else in, so much more information is kind of redundant, and just offering reassurance, saying we will take care of everything. I think she asked me, can I see him? And I was yeah, obviously, you absolutely can. Let's just get you a cup of tea. And is there anyone you want me to call? Offer to break the bad news to someone else, maybe a sister or their husband or whatever. And you just have to be super nice, and like you would be at work. Like I said, there'll be loads of books on this, there'll be loads of articles. This is a practicable skill, so if you're not good at it, practice it. So then following the communication, I then had the abdominal examination, and the setup in this room was not ideal, I would say. The other rooms were really nice and spacious and bright. This was dark and cramped. For whatever reason, this abdominal station did not go to plan. I think maybe I was becoming tired, maybe I was a bit bored of the whole exam, maybe I'd lost focus, but I went in, went through the motions, exposed the patient, had a look from the end of the bed. I found that he had a fistula on his sort of left arm, and there was recent needling, so he was clearly a dialysis patient and was having active dialysis. Carried on doing my peripheral exam, looking for any clues of the etiology of his kidney disease, and whether he'd had previous dialysis, other dialysis, renal transplant, that kind of thing. Found some old, probably peritoneal dialysis scars. However, the whole time I hadn't really exposed him around the belt line, and I didn't really check at the start. I got him to cough, but I hadn't exposed the belt line, so I wasn't really able to ascertain whether he had or hadn't got an inguinal hernia. Again, when I was examining his abdomen more thoroughly, I didn't pull his belt line down to sort of expose the top of his groins. And this kind of thing, it's not the end of the world, but as I was finishing my exam and literally feeling his ankles to see if he was euvolemic, that kind of thing, I then was oh my gosh, I haven't done that. Does this guy have a transplanted kidney that I've not seen that is failed, or is there a scar there? Has he had it out? Or I hadn't examined that part of him, and that really got to me right at the end. And I was then thrown straight into my presentation. Although it was a small detail, I was then panicking, oh gosh, I haven't examined. Realistically, I dropped a few marks, but then I let it get to me and I dropped more marks because my differential diagnosis and my presentation was frankly not very good. Yeah, you have to try and just literally move on instantaneously, and obviously that's really difficult. And I had this realization just as I was going into the presentation. I think I let it get to me and probably dropped more marks than I needed to, and all I would say is just try and move on. It's so hard, but at this point I had to have a pep talk with myself to just sort of recover my psyche for the rest of the exam. So after that, I sort of had a bit of a pep talk. Like I said, I was outside, and before flipping over onto the next sheet, I just sort of sat for a moment. I asked myself to concentrate. I also said, the exam has gone okay. You have a chance of passing this, but actually this exam and passing this exam depends on you nailing the next one. And you could pass this exam if you do well in the next one, and you could fail this exam if you don't. And I kind of just regain my focus. Sometimes it's really hard to do that, but I was calm enough to be able to actually bring it back, forget about the abdominal exam and just focus on the last exam. Flipped over the page and went on to scenario 5, which was the second consultation. In all honesty, I can't quite remember the details for this one, which is really annoying, but I do remember the gist. And basically, the brief on the last scenario was about a younger man who had reported either exertional breathlessness or dizziness whilst playing football. I don't think he'd had loss of consciousness. Maybe he had, but essentially it was like cardiovascular symptoms on exertion whilst playing football, and he's a young man. I was given a set of obs and his systolic was like 130, so like subtly hypertensive-ish. You're then asked to see him in clinic. There wasn't very much to go on in the history. I obviously started talking about his dizziness and breathlessness and loss of consciousness and went through all of that. He didn't have any chest pain and didn't really have a significant past medical history. Family history, he had a grandfather that died in his 60s from a heart attack, so like not uncommon, but like not significant family history, no smoking or travel history. And then I asked him about his drug history and whether he was taking any medications. And at this point, he offered me a list and actually had Ramipril 10 milligrams and Indapamide 2.5 milligrams. And at that point, I was like, okay, so this guy has hypertension. He'd been on these meds for like over a year, and then these symptoms had been like a subacute presentation, so maybe like the last few months he'd been having these sort of like cardiovascular systems on exertion. I then asked him about, have you had any scans or any tests as to why you are hypertensive, and he said no. And so then I was like, okay, so this is a like hypertension without any look to the secondary causes of hypertension. I asked him about symptoms of hypertension, any like visual loss, any blood in the urine or any headaches, that kind of thing. I asked him about pheochromocytoma and whether he had any sort of like spells of sweating or palpitation. I asked about kidney disease, went on to examine the patient in a very like loud systolic murmur. I think in reality this patient was a cardiac patient that had a VSD or an ASD, and he was then given this script of, you know, you're going to play this guy that also has hypertension. Whether he did or didn't have hypertension, I don't know. The rest of the exam was fairly normal. I went on to sort of just discuss it with the patient and explained that actually there were a few things going on that I think needed sorting out, that his symptoms were significant and we needed to investigate them. I said that he had high blood pressure. Normally when you have high blood pressure, you should have that investigated, and he hadn't had that. So there were things that we needed to do, like a kidney scan. Also explained that he had a murmur. I said that I'd like to investigate that a bit further. I said that the fact that he was having this dizziness spells also meant that I wanted to do an ECG, look at a longer ECG, so a 24-hour tape, and then also get a look at his heart via an echo. And I sort of said that I didn't really know what was going on at this point, and there was quite a lot of information to gather before we might have an idea of what was going on. Compared to like the trigeminal neuralgia, I felt like there was loads to talk about in this one, and again, it wasn't like necessarily you had to do it one way or the other. It was just like testing. Do you pick up the things that are wrong with the patient, and then how do you package that into a sensible management plan, and you talk about it competently and sensibly. So when I went to question the examiners, I told them my main findings. I expressed my differentials for the causes of secondary hypertension and the screening, and then I also talked about the fact that he had cardiac symptoms as well as systolic murmur, and I mentioned that, you know, I'd be thinking about HOCM. I also talks about aortic stenosis, although less likely, and then I mentioned like VSD, arrhythmias, that kind of thing, as to why he was symptomatic. That was the station, and I hope that was helpful. Again, if this is helpful, please send it to your PACES group. They would love to hear what my exam was, and it's really helpful. So then the last thing to talk about in this very, very long video is the marking and domains. PACES is marked across 7 domains, and you have to pass each domain, but you can completely destroy yourself on one station and still pass this exam, which is a good thing. You have to use that as an opportunity, and in order to do that, you have to stay calm, and you have to let yourself move on to the next one. So looking at my mark scheme, I came down in the usual areas that people struggle, which was identifying physical signs mostly. So this is the domain that most people come down in, and I imagine I lost my marks probably in the cardiovascular station and also in the abdominal station. I don't think I picked up neck scars probably. Maybe he did have a kidney, I don't know. The other thing that I lost marks on was differential diagnosis. I think this was probably when I lost my bottom in my abdominal station. And then my exam was over, and that was like a huge relief. I went to the beach and just got a coffee. I hope that was helpful. It's a very long video. Like I said, use this as a guide, come back to it if it's helpful. Please, please, please share it in your PACES group. It is actually quite a lot of good information in this video. I'm one of the few people that have sat and passed the new PACES 23 exam, so please, I hope this was helpful. If you're keen to join my accountability group, like I said, I found it so helpful in keeping track with my revision, and like I said, I wasn't in there with anyone else who was doing PACES, so it's open to everyone. It's completely free. It's on a Sunday, 9 AM, This Sunday is our first one, the 7th of January, so make sure you check that out in the description. Hit me up with any questions. I do reply to comments, so just comment them down below. Good luck in the exams. Like I said, this is a tricky exam. It is passable, but do not conflate your self-worth as a person or as a doctor with the result of this exam. It is completely irrelevant. It's a hoop that you have to jump through, just like the driving test, and I wish you all the best. In the next video, I will cover things like courses and resources that I used. I don't think I can do that in this video. It's way too long. Thanks a lot, and I'll see you in the next video. Cheers. Bye.